So much. So David, I'll just introduce you first, and then you can start the presentation after that.
Okay, perfect.
Thank you so much, everyone, for joining the Health for the World International Grand Rounds. We are really honored to have our International Grand Round speaker today. Our speaker is Dr. David Epstein. Dr. Epstein is a medical director of MVP Pediatric and Urgent Care in Tarzana, California. Dr. Epstein also has extensive background in critical care and works at Pediatric ICU MD at CHLA. We are really honored to have Dr. Epstein talk to us about wheezing in children, which is an important topic worldwide. Thank you, Dr. Epstein, for giving this talk, and you can start whenever you are ready.
Okay. All right. Thank you so much, Dr. Hani. Thank you for reaching out to me and inviting me to do this presentation. We'll get started and go from here. So the objectives of this talk are to kind of define wheezing and look at the pathophysiology of wheezing and evaluate like differential diagnosis of wheezing in children, because it's often different than what you see in the adult population, and look at general treatments for wheezing. And we'll kind of do a little bit of a wrap up. But I think the impetus for doing this talk in general was that wheezing is a very unique entity in and of itself, and it's very fascinating because of the things that can cause it. And really, wheezing doesn't denote any one specific disease, and a lot of things should be considered, especially when you're dealing with children. So just some basic information with wheezing. It's defined as a musical high-pitched whistling sound produced by airflow turbulence, and it's usually apparent on expiration, although at times I have seen or heard it on inspiration with specific diseases. But I think most of the time we feel that wheezing is an expiratory phenomenon. And when we think of breathing in and of itself, the difference between wheezing, or as I term like asthmatic breathing, is different than vesicular breathing, which is the shallow cadence that you have with normal breathing. It's a quiet respiration, which you can hear throughout the chest, whereas the asthmatic breathing is typified by the high-pitched whistling sound. And with vesicular breathing, there's more of an emphasis on inspiration. It's longer, and there's a short exhalation phase, where with quote asthmatic breathing, it's more of a short inspiratory phase and a long exhalation phase. And sometimes it can be pretty significant. I know in the adult population, there are other reasons for wheezing, but most of the time with kids, and if you look at the asthmatics that we see, if they're having difficulty breathing because of the pathology that's going on, they typically present as the strong exhalation phase, and it's a forced breathing out pattern, to the extent where sometimes it takes a lot of musculature to do that. And we see kids doing what's called tripoding, which is they're sitting and they have their hands outstretched on the table in front of them, and they're actually using their whole effort to breathe and to exhale, because it's actually more of an active process, whereas vesicular breathing is very passive. And at the end of the talk, if anybody asks any questions about lung volumes and things like that, the physiology of that, we can go through that as well. But it can be pretty dramatic when you're seeing that. And the fact is well, we can go through it a little bit later with regards to asthma and the findings with asthma. But if you have an asthmatic who is actually not having wheezing, and they look like they're having trouble breathing, that's actually worse than hearing somebody who does have wheezing, because that means that their airways are so closed off, they're not actually moving any air at any point. And really the physiology of wheezing, the whistling sound that we hear, is based on turbulent flow. And laminar flow is basically kind of an ordered velocity of air movement through a, as you say, kind of like a tube, where it's much higher in the middle section of the airway than towards the edges, whereas turbulent flow, there's more axial flow or disorganized flow, and causes eddies within the airway, and therefore creating more of a generation of sound. And sometimes people have thought that that the airways themselves of wheezing is due to kind of a little bit of a fluttering of the airway, and this is brought about by the turbulence that's seen. And these are particularly important formulas for me. We use this all the time in the ICU, and thinking about or conceptualizing flow, in which case the airways are an important part of that. The flow dynamics can also be applied to fluid flowing through the blood vessels and whatnot. But I think it's particularly interesting in the airways. And the flow formula is kind of a derivative from Ohm's law, which is the electrical formulas in physics that we see, but it can also be applied to human physiology and in airflow. And basically, the flow is determined and is proportional to the change in pressure upstream minus the downstream pressure, and it's inversely proportional to the resistance of the tube. And the resistance is interesting in that resistance is proportional to the viscosity and the length, where it's inversely proportional to the radius to the fourth. And why I find this fascinating is because when you have children, let's say upper airway disease, which is prominent during our summer months, we have what's called croup, which you get a inspiratory whistling sound, stridor, and that's from upper airway narrowing. Well, in children and adults, they both can get infection with a virus, parainfluenza virus, causing croup, but they react very differently. And children, we always say, are not small adults because their physiology is actually different, and actually their anatomy is a little bit different in that their upper airway is relatively more narrow to begin with than adults. And so as they grow, it proportionally gets larger. But as a child, any small increase in swelling in the subglottic area can cause a significant increase in resistance because it's such a smaller area. And so we look at this principle in that manner as well. And in point of fact, you may have a lot more experience with the adult population in the ICU and seeing things where you're doing resuscitations. And one important principle in resistance that we think of is the difference between using a central venous catheter to infuse fluid versus an IV to infuse fluid, in as much as that you would think that a central line is something that's more stable to administer fluid at a faster rate, when in point of fact, because of the resistance formula, that if you have a larger, shorter tube, like an IV, like a large gauge IV, you can actually get more fluid into somebody much more quickly than you could in an actual central line. So in point of fact, I'm kind of going off on a tangent a little bit, but this formula of flow, especially in the airway, is really dependent upon the pressure change and the resistance parts of the formula. And when we talk about wheezing, the resistance plays a big part in the flow restriction that we see with various diseases that we'll go through. So when we think of a differential of wheezing in children, it's a pretty good list of things, from asthma, which is much more common, to bronchiolitis, of which we usually see respiratory syncytial virus, to heart failure. And yes, kids do get heart failure, and it can be typified by overcirculation from different congenital heart lesions. causing left to right shunting, pulmonary overcirculation, to foreign body aspiration, aspiration pneumonitis, cystic fibrosis, usually in infants, will cause the wheezing, to a number of other congenital anomalies or external compression of the airways that we see. But I'm going to talk about the ones in red: asthma, bronchiolitis, and congestive heart failure, because those are some of the more common things that you will come up with. But it's important to keep in mind that other things can cause wheezing in children. But the first thing in asthma, and going by the United States, and we see it's a leading cause of chronic illness in the United States, and almost 10% of the children in the United States have some form of asthma. And so it's something that we commonly see and needs treatment. So the pathophysiology of asthma is characterized by airflow obstruction. Usually we think of distal airways, the small airways, and you get a decrease in airway diameter and increased resistance, as per the formula that we just went through before. And asthma is typified by an airway hyperresponsiveness, a bronchospasm of bronchial smooth muscle causing contraction, and an airway inflammation with mucosal edema and mucus plugging of the small airways. And this is brought about by a cascade of inflammatory events that starts off with degranulation of mast cells. And basically they release histamines and leukotrienes, which activate the smooth muscle to contract. And they also have recruitment of lymphocytes and eosinophils. And there's a whole host of inflammatory, like cytokines and chemokines, that get released, and they can cause damage to the mucosa, increase mucus production, and increased reactivity of the airways. Also, there can be a sympathetic or parasympathetic component as well that can cause some irritability of the airways and cause muscle constriction. And the typical pathophysiology or the breathing mechanism of asthma is somewhat what we discussed earlier. During inspiration, the negative pleural pressure actually causes a physiologic intrathoracic airway dilation. And during expiration, the pleural pressure approaches zero, causing physiologic intrathoracic airway narrowing. And remembering that the airways themselves are not they're not lead pipes. They're not stiff, and they're actually flexible. And so it becomes actually easier to take a breath in, and there's more obstruction with expiration because of the pressure changes in the thorax. And this is what you get typically with asthma, is getting the air trapping, which you see. And this is typified by the pressure changes within the airways and in the pleural space. And one will see, as you note on the diagrams here, is that you're taking pre-inspiration, inspiration, and end inspiration. The airway diameter can often be determined by the transmural pressure. We see this physiologically in the blood vessels in the heart as well, but in the airways it's interesting. So the transmural pressure is determined by the intraluminal minus the extraluminal pressure. And so what happens is as you're taking a breath in, and you can see the numbers here from 0 to negative, you take that number and you minus the number on the outside of the pleural pressure. And at these times of inspiration, you can see they're negative numbers. So it's like 0 minus -5, which is +5, which is a outward distending pressure. And the same thing during the other phases of inspiration. However, at some point when you're doing expiration, as the pressure builds up, outside of the airways, and you're taking a breath out, and let's say there's a pressure drop from here to here, so you're looking at +19 minus a +30, you're actually dealing with a negative transmural pressure of -11, which then causes a collapse of the airway. And so that's a very interesting phenomenon. In point of fact, when you look at lung volumes, there's what's called the reserve reserve volume, where there's a volume within your lung that you cannot breathe out, and there's a residual volume. Sorry, the residual volume where you cannot breathe out, and you can force exhale as much as you want, but at some point, the airways collapse, and you can't breathe out all the air in your lungs, and so you have a residual volume in that capacity. And with certain diseases, that closing pressure of the airways, is brought up with a higher volume that's trapped within the lungs, and you see kind of phenomenon here, which you have a child with asthma, and it's typified by hyperinflation of the lung fields. You can see flat diaphragms here. Also with asthma, it's not necessarily a homogeneous disease process, and that one thing is going on. So you have hyperinflation, but you also have some diffuse dispersed atelectasis. And in point of fact, when you're dealing with somebody with asthma, you often think of CO2 retention, but in point of fact, when the beginning stages, they're actually hypocarbic because they're tachypnic because of the physiologic changes of the lung volumes and the difficulty in breathing. And also there can be some hypoxic or hypoxemia causing increase in the respiratory drive, in which case they may actually become hypocarbic. And with asthmatics, as an intensivist, we would often fear the normal carbic child with asthma, meaning that their retention of CO2 is increasing slowly, and it may look like they have a normal CO2 level. But in point of fact, that may be an indication that they're tiring out or they're not compensating as well. And when they become hypercarbic, you're already behind the 8 ball in that respect, and you're in trouble. And things need to move quickly at that point. So, all right, going to the next slide. The next entity that we'll talk about that causes wheezing in children, and most commonly in infants, is bronchiolitis. And that's kind of like a broad term that we use for a viral disease. And respiratory syncytial virus, or RSV, is the most common pathogen. And this usually affects children less than 2 years of age, but we see the peak in the age group less than a year of age, and it usually causes the most difficulty with infants because of their respiratory mechanics. And it usually occurs during fall and winter time. Those are the most prominent times for that, and it's one of the most frequent causes of infant hospitalization in the United States. And high risk factors for infants include prematurity, immunocompromised status, bronchopulmonary dysplasia, or BPD, which is often it's basically disorder of the lung as they're being exposed. Let's say if they're in the neonatal ICU and have been on the ventilator or exposed to high amounts of oxygen early on, it causes a disease of the lungs called bronchopulmonary dysplasia, and then congenital heart disease. And so these infants are often at high risk for developing respiratory distress or respiratory failure due to bronchiolitis in that respect. And it's interesting how RSV affects the infants, but then later on, it can predispose these children to wheezing as well later on, in which case they can have recurrent episodes of wheezing anywhere as upward to 7 or 11 years of age. And it's thought to due to the damage to the bronchial epithelium. And when we think of children and their lung development, their lungs are still developing up towards around 7 years of age as well. They're, from a physiologic standpoint, their lungs are still growing. And so the pathophysiology of bronchiolitis is interesting in as much as that it's an infection of the distal bronchiolar epithelial cells, and you get submucosal and adventitial edema from the infiltration of inflammatory cells. You get excess production of mucus and an increased proliferation of goblet cells, which contribute to the production of mucus. And then you get cellular swelling, necrosis, and sloughing of these cells, which causes the typical situation of narrowing and blocking the bronchioles with mucus plugging and cellular debris, and then edema in the lower airways. And it's pretty fascinating if when you see infants or young children with RSV or respiratory syncytial virus, they often have the appearance that they're blowing bubbles with their nose. I mean, there's so much mucus. You can sit there and suction out mucus like every 5 minutes. It just keeps coming, and you don't know how they're producing that much, but that's what happens. They're almost drowning in their mucus, and it really affects their airway and their breathing. And bronchiolitis itself, well, I mentioned that RSV is the primary cause, and things that we think of typifying bronchiolitis: rhinovirus, influenza virus, human metapneumovirus, coronavirus, although probably a different coronavirus than we're dealing with now, adenovirus, parainfluenza virus, all different viruses that can cause a bronchiolitis type pattern. And it's interesting that with bronchiolitis, you get the airway obstruction, you get hyperinflation, you get increased airway resistance, you get collapse of the airways, and you get ventilation perfusion mismatch, in as much as you get areas of dead space, ventilation, and you get areas of shunt within the lungs from the atelectasis. So you get a mixture of hypoxemia, and you can also get CO2 retention as well, where areas of the lung are ventilated but not perfused. So, and then another interesting point about bronchiolitis, and we'll refer later to treatment, is that bronchiolitis, that smooth muscle constriction is not thought to be as much of a player in the pathophysiology as is something like asthma, and the inflammatory response is more of a neutrophil infiltration rather than the infiltration with like eosinophils or mast cells that you see with asthma or kind of more allergic pathologies that cause the wheezing. And here's kind of a typical X-ray of RSV bronchiolitis, and you will see a little bit of hyperinflation, but you can also see a lot of patchy atelectasis, and sometimes infants can get infiltrates there as well. But when somebody's diagnosed with RSV, we often think of it as the primary disease, and we don't typically put them on antibiotics. That's not to say that infants and children can't get pneumonia from a prior viral illness. And in fact, we often think of that as the setup for pneumonia later on, but typically we don't put them on antibiotics initially, even though they have a pattern like this. And bronchiolitis in pediatrics is usually a clinical diagnosis, and we don't often necessarily need testing, although it makes us feel better if we diagnose somebody with RSV, then we know what the clinical course is. And I often able to counsel the families as an outpatient and say, look, this is what's going to happen, and this is what could happen. And so you need to be careful about, these are the things to look out for. And the things, I know I'm maybe jumping ahead a little bit, but the things that we watch out for RSV bronchiolitis is that infants, they have trouble feeding is one thing, and they have trouble breathing. And the reason they have trouble feeding is because they're breathing so fast and they're concentrating more on breathing than they are on feeding, and they're obligate nasal breathers. And so when you have an infant with RSV and they're trying to breastfeed, they have trouble feeding because they can't breathe through their nose at the same time. And so they end up getting dehydrated because they can't feed well orally because they just can't breathe and feed at the same time. And then they also have issues with increased work of breathing, and they can develop respiratory distress. And those are some things that we counsel families about as things progress. And I always say to families that, the onus is on us to determine, when your child needs to go to the hospital or get admitted. And if you have any concerns, you can, always, see your pediatrician or your medical provider, as much as needed in order to avoid, complications at home. So we do that teaching as well. Okay. So when we go to another cause of wheezing in children, it's we look at congestive heart failure with pulmonary edema, and I know that this is a fairly common etiology or pathology in the adult population, but in kids it's very relatively rare, but it is something to keep in mind. And congestive heart failure in the United States, in the pediatric population, is estimated to range between 12 and 35,000 cases per year in the US. So it's not very common. And in fact, congenital heart disease itself accounts for about 1% of the pediatric population. And congestive heart failure with that is even a smaller portion. And it's different than adults. With adults, I think you think of more of the chronic diseases, atherosclerosis or myocardial infarction or things like that causing a degree of myocardial dysfunction. But in kids, it's typified by myocardial heart diseases and structural heart diseases. And that's typically what we see. And here are just some a differential diagnosis of pediatric heart failure. And you can see on one side, it's basically structural heart disease, and it's very fascinating. And actually, I spent 16 years in the cardiac ICU and taking care of pre and post-op congenital heart defects, and it's very fascinating physiology. You have things with volume overload, and where fluid gets pumped into the lungs through defects in the heart. And some of these can be like as simple as a ventricular septal defect, and it goes from the left side of the heart to the right side of the heart into the lungs, and you get pulmonary overcirculation and edema with heart failure in that respect. And you can see it with atrioventricular septal defects, where there's a defect in the atrial septum and ventricular septum, and then there's a common AV valve, patent ductus arteriosus, which are more extra cardiac lesions along with aortopulmonary windows, which is basically a defect where there's direct circulation coming from the aorta, and that persists, and blood is pumped into the lungs that way. Valvular regurgitation, which is maybe more of a common phenomenon in the adult population. Aortic regurgitation, mitral regurgitation, which are on the left side and produce congestion and backing up of blood into the left atrium, and then hence the pulmonary vascular system, creating edema in that respect. And then you get pressure overload lesions. And on the right side of the heart, we'll often see kids with what are called like total anomalous pulmonary venous return, where the pulmonary veins return anomalously to different parts of the heart. And they can also have stenotic vessels, in which case you will get a pattern of pulmonary congestion just because the blood can't make it back into the heart as well, because there's stenosis of those pulmonary vessels. And then you have critical aortic stenosis or coarctation on the left side, which obstruct flow out of the left side of the heart. And in that manner, you can also get left ventricular dilation and increase in mitral regurgitation, left atrial enlargement, and pulmonary vascular congestion as well. And then there's some other more complex congenital heart lesions, which you get transposition of the great vessels, which is switching of the aorta and the pulmonary artery to the other sides of the heart. So the aorta is coming off of the right ventricle, and the pulmonary arteries coming off of the left ventricle. Or you get a common atrial trunk, in which case it's a conal truncal defect, in which it's called truncus arteriosus, in which case there's just a single vessel coming off of the heart instead of an aorta or a pulmonary artery, and you get the pulmonary branches coming off of this vessel. And so you basically have one track going out of the heart, and that same force of blood going to the body and the lungs at the same time. And it usually goes the path of least resistance, in which case you get pulmonary overcirculation from that standpoint. And you get a number of other things, as well as single ventricle physiology, which is a whole talk in and of itself. And then you finally get myocardial heart disease due to cardiomyopathies, dilated, hypertrophic, and restrictive cardiomyopathies, which are fascinating, and also cardiomyopathies related to arrhythmias, and on rare occasion, myocardial ischemia. And then you have systemic diseases like sepsis, or pulmonary hypertension, or thyrotoxicosis, or even we would get myocardial dysfunction after a cardiopulmonary bypass, after some of these congenital heart lesion repairs. And you can also get infection of the myocardium with viral diseases, and that can cause myocardial dysfunction as well. So we get like a myocarditis in as much as we see in kids, but these are often quite rare in children, but need to be thought of. And the pathophysiology is, as we were kind of talking about the differential on the last slide, is left-sided heart failure causing, or pulmonary overcirculation causing pulmonary edema. And you get a narrowing of the airways, like an airway obstruction, because of the edema of the airways. And in children, sometimes we don't hear crackles. We don't hear signs of fluid in the alveoli. And in adults, the heart failure is typified by JVD, or jugular venous dissension, crackles on exam, and lower extremity edema. Whereas in kids, their appearance may be quite different. And in infants, heart failure is often typified by increased work of breathing, decreased feeding because they don't have the energy to feed, sweating with feeds because their heart is in failure, and feeding is like running a marathon to them. And so they often show signs of respiratory distress while feeding or sweating. They don't grow. And so you'll have these infants who are, as you follow them on their growth chart, they fall off their growth chart, as they say, and their percentiles of growth become markedly diminished because they lose weight because of their myocardial oxygen demands, and that their body can't keep up with it. They have pallor and decreased activity. They're just quite not as active as the normal infant or child. And when we see with adults, we see adults who are doing their activities and become short of breath, and we ask them about walking upstairs and activity and how they're able to cope with that. Whereas children are very fascinating in that respect, is that they will limit their own activity before it's actually noticeable that they have the disease. And you'll have a child who will start off with being a very active child, maybe playing outside in sports, and then maybe they decide, okay, well, I'm just kind of tired. I'm going to start, doing more like, reading or, playing video games, or then they're just kind of sitting on the couch, just kind of, relaxing more or watching TV. And so children will often regulate their own activity in that manner. And because they don't have the energy to do the things they did before, they tend to choose activities that they can do. And so you'll notice a decrease in their activity, not necessarily shortness of breath or things like that that you see in adults. And they'll look a little bit pale. And one thing that's very interesting, I find fascinating with the pediatric population, is that their cardiac physiology is a bit different. And infants less than a year of age usually can't increase their stroke volume. And we'll talk about later, just a brief cardiac physiology, is that heart rate and stroke volume are the determinants of cardiac output. And in infants, they can't really generate a larger stroke volume. And so they often will increase their heart rate in signs of failure. And that's what we see typically before there's any hemodynamic changes. is that their heart rate will increase. And the heart rate will also increase with other increase in metabolic demand, whether it's a fever, or they're having trouble breathing. And in order to increase their cardiac output to maintain oxygenation and delivery of nutrients to the organs and cells, that they increase their heart rate. So we think of in children that a heart rate is a very sensitive indicator. If they have some myocardial dysfunction, the heart rate, we monitor that as an increase or a worsening of their clinical condition. So pay attention to heart rate in children because it can really reveal a lot of things. Oftentimes, I mean, yes, it can be from anxiety, it can be from crying. We see that often. But if there's a sustained increase in heart rate in a child or an infant above the norm for age, it's very important to note that and investigate why that's happening. And every child has a different heart rate range per their age. And so you'll have infants who will have a heart rate that could be, normal, like 140s, 160s, where you would say in an adult, that would be like, oh my God, they're gonna crash if they have a heart rate like that. Whereas, a young child may have a heart rate in the upper 90s, low 100s, and we don't even think anything of it. And then also with heart failure, because there's the cardiopulmonary interaction part of it, is that they will be tachypnic, they'll have some retractions, nasal flaring, tracheal tugging, and this is often more common or more typical finding in infants with heart failure, just because their physiology is different. You think of adults with more calcified bones, and the ribs are much stiffer, whereas infants, they're more cartilaginous, and so the retractions are often much more evident than you would see if in an adult. And so typically infants get into a lot more respiratory difficulties when they have heart failure from that respect. And also another note is that on exam, adults, it's sometimes harder to feel the internal organs, whereas in infants it's very easy. And we often use the liver as a sign of heart failure, in as much as it's kind of like it's a really good indicator, because you can feel it very readily in the size of the liver below the right costal margin. So when we're looking or examining kids in the ICU and looking at their degree of heart failure, we check their liver every day, and in as much as some of the other physical findings, but the liver is a pretty sensitive indicator of worsening heart failure too as well. So. And so this is a typical X-ray of a child with an enlarged heart and increased pulmonary vascular congestion that we see, and they can have obviously have wheezing because of the airway obstruction caused by the edema within the airways from the pulmonary congestion and heart failure. So the reason I bring up all those entities and the differential of wheezing is because they all have different treatment modalities. And wheezing is not, there's not one management style to treat wheezing. And with asthma, bronchiolitis, and congestive heart failure, they're all different treatment plans. When you look at asthma, depending on the severity of the asthma, oftentimes the kids are they're breathing fast, they're not drinking or eating as much because they're focusing more on their breathing. They'll become a little bit dehydrated, and so hydration will be part of what you need to do. Not overhydration, but maintenance and making sure that their intravascular volume is adequate, because they get a lot of sensible losses with rapid breathing. Also, in cases where they're a little bit hypoxemic, they may need a little bit of supplemental oxygen. But the mainstay of treatment for asthma is the inhaled beta agonists to help relax the smooth muscle, and corticosteroids to reduce the inflammation, which is causing the airway edema. And so if you can break the cycle with those two agents, that can get you pretty far. And in point of fact, a lot of kids respond in outpatient with inhaled beta agonists. Like in the United States, we use albuterol, And it's, relatively common in kids that have worsened or more chronic illness. They'll require corticosteroids for what we call like a steroid burst to try to reduce the inflammation, help get them back on track. If they make it to the ICU or the hospital, they may require things like the beta agonists in IV form, which we use like terbutaline in those cases, and methylxanthines like theophylline or aminophylline, anticholinergics to help fight the parasympathetic responses, sometimes magnesium sulfate and sometimes Heliox, which it's a helium oxygen mixture, which helps decrease the airway resistance a little bit to improve the work of breathing. And some of these modalities work, and not everything's really 100% proven in children, but we often will start them on a lot of therapies initially and peel things off. And that's, my philosophy when I'd be in the ICU and see a child with asthma. You kind of hit them with everything and you put it on all these medications, and then you peel them off as they start to get better, just because it's hard to catch up if they're already in respiratory distress. And sometimes these kids end up being intubated because they're having trouble breathing and they have a lot of air trapping. And bronchiolitis is a little bit different in as much as we mentioned before that they have the inflammatory process rather than an allergic infiltration of inflammatory cells. This is more of a infectious inflammation of inflammatory cells. And, they have to be monitored carefully, as I mentioned before, because it's not uncommon that these children require some kind of respiratory support. Sometimes we use high flow nasal cannula to augment their breathing, help support them to intubation and ventilation if necessary. And because of the mucus production and the airway disease, they may need some supplemental oxygen. But as I mentioned before, hydration and nutrition may be very important in these children because they're focusing more on breathing than feeding, and they can get dehydrated. And also they need nutrition in order to keep their activity and their energy. And so sometimes children will be admitted to the hospital, not necessarily even for respiratory support, in as much as IV fluids so they can maintain hydration, or NG tube feedings, with putting a nasogastric tube in just so they can get the nutritional support and stay hydrated as well that way if they're not in too much respiratory distress. But it's hard to feed an infant if they're breathing 60, 70, 80 times a minute. I've even seen kids, infants breathing 100 times a minute. So it's something where in adults would be unheard of, but in infants, they can breathe pretty rapidly in that respect. And removal of mucus obstruction from the nasal airways using nasal saline drops. And the mucus, as I mentioned before, it can be like bubbling. You see them blowing bubbles with mucus from their nose. And sometimes they just need to be admitted to the hospital just for the frequency of the suctioning, which could be very frequent, every 5 minutes, every 15 minutes, but just more frequent than can be done at home because it's around the clock and could be done for days. And also you kind of want to avoid a little bit of excessive stimulation because they're already having trouble breathing as far as the infants go. And you want them to kind of relax and focus on that rather than being agitated from something else and crying, which can make things a little bit worse. When you talk about bronchodilators, it's a very often controversial subject when it comes to bronchiolitis, because it's really difficult to distinguish bronchiolitis from an acute asthma or wheezing exacerbation from a viral illness. And we see this all the time as kids come in with a cold and they have wheezing. Bronchiolitis has wheezing. So do these kids with viral illnesses have asthma? Not necessarily, but the viruses can cause sometimes bronchospasm, which does respond to albuterol and causing relaxation of the airways. But the typical thought is that, and the recommendations among the American Academy of Pediatrics is that bronchodilators are not a useful therapy with bronchiolitis. However, in real life, in the outpatient setting, we will try an albuterol nebulizer treatment to see if it helps. And if it does help the wheezing and looks like it helps the work of breathing, then we will prescribe that for home use. But that's in no, it doesn't mean that that's going to help the outcome in as much, reduce the risk of hospitalization or things like that. But it may make the symptoms a little bit better for the child. And one of the things that's interesting about bronchiolitis is that we talked about the mucosal edema and the inflammation that happens. And this is not a phenomenon where you use steroids. You don't use steroids in these kids. It doesn't help. And it's counterintuitive because the point is that they don't, it's not an allergic response or something where the airways will get better without the inflammation. It's that it's fighting an infection, and you give them steroids. There's a chance that you could make things worse. But the one thing that's very interesting is that some people have used, and I remember we used it in the ICU, is using nebulized epinephrine, and the reason why we use that was to help reduce the mucosal edema in as much as causing restriction or constriction of the blood vessels to reduce edema of the airways in that respect. And it would seem to help some kids. And so that was pretty fascinating. But pure beta agonists in that respect are not typically thought of as to be very useful in bronchiolitis. And finally, we look at wheezing in children caused by congenital or congestive heart failure and pulmonary edema. And I put this slide up here because the treatment of heart failure in children, you really need to know what the etiology of it is. And it's, again, one modality does not treat everything, and it depends on the kind of heart failure. And some of these things, when we talk about cardiac output and the heart function, it may be fixed from the fact that they need a heart surgery. They need closure of that ventricular septal defect or repair of that truncus arteriosus, and that may be the reason that you're doing it. But some of the treatment for heart failure in kids can be dependent upon diuresis, where you're trying to remove fluid, and they may not have necessarily severe myocardial dysfunction. It may just because they have pulmonary overcirculation. You're trying to reduce the amount of pulmonary overload so that there's less pulmonary edema. But this goes back to this formula here, or this diagram here, and I like to teach it to the residents and fellows when we're dealing with cardiac physiology, is that in children, blood pressure is an important indicator, but it's not the the blood pressure can be maintained. And so if you're seeing an abnormality in the blood pressure, if the blood pressure is low, you've already missed the window for treatment, and they're already in a lot of trouble because kids can compensate pretty readily in most cases. And it's really until the point where they're decompensating means that their compensatory mechanisms are gone, and you're already missed the treatment window, and you're probably going to end up in the ICU. So, as I mentioned before, cardiac output and systemic vascular resistance determine blood pressure, but cardiac output is determined by heart rate and stroke volume. And really, the stroke volume part is really variable in the pediatric population. As I mentioned, the infants can't really increase their stroke volume, so they depend on the heart rate to compensate for their lack of cardiac output. Okay, and if you see an infant who has cardiac dysfunction and they're tachycardic and they're not being treated, and all of a sudden their heart rate starts to slow down, that's a sign that they're going to arrest. So that's just they have a cardiac arrest. So that's just a little nugget of information there. But and the stroke volume is really dependent on the preload, afterload contractility, and lusitropy, which is relaxation of the heart. And all those modalities are treated by either diuresis or augmenting the cardiac output or reducing the afterload to improve the cardiac function. And when we talked about those three entities, we also have to keep in mind that there are other things that cause wheezing. And this was a child we actually saw in our clinic who just had wheezing, and you can see the X-ray on this side, and there's whiting out of this area of the lung field, and this is 2 months later after they pulled out a teratoma out of the chest. So tumors can also cause wheezing, as they cause external compression of the airways. And then one other thing too is that children, because they're getting into all kinds of things, they can aspirate things, and this can cause obstruction or a ball valve effect, in which case you'll see X-rays with asymmetry. You'll have one area that's hyperinflated, one side, and the other side is normal. Well, this side, even though the object, which is probably obstructing the airway, is not radiopaque, you can imagine if there's wheezing on one side and reduced airflow movement, you get hyperinflation, that you have an aspirated foreign body in that area. So in conclusion, wheezing is a sign of increased airflow resistance, and the airflow resistance is variable depending upon the underlying disease that you're dealing with. And the treatment of wheezing really depends upon the cause of wheezing. And while asthma is one of the most common causes of wheezing in children, we have to always remember that we say in pediatrics, all that wheezes is not asthma. And keeping that in mind, that going through the differential within your mind on what could be causing the wheezing, and that should direct your therapy and what you're going to do. I think, and then thank you for listening and inviting me to this talk. And if you have any questions, you can feel free to reach out to me on my email or reach out to me on Twitter as
well. Thank you so much, Dr. Epstein. I just want to ask, does Dr. Nyangya, do you have any questions? I can unmute them.
Hello, can you hear me?
Oh, yes, we can hear you now. Yes, go ahead, Albert. You can.
Yeah, it's not Dr. Albert. Thank you, Dr. David, for the presentation.
Thank you.
Yes, so thank you for making it clear. So bronchiolitis, usually bronchodilators are not useful, and if the patient comes in, the child comes in and has wheezing, and we are in doubt whether it's bronchiolitis or asthma, we can give a trial of bronchodilators if I got it correctly. And if it improves, then fine, it's helpful. If it doesn't, and we strongly suspect bronchiolitis, then bronchodilators becomes useless. We don't need it anymore.
Exactly. And one of the things that we stressed in the ICU, one of the things that we think of is that all that wheezes is on asthma, is that you look for those unusual causes. That if your bronchodilator is not working, you have to think outside the box. And we're very cautious, and I always teach the residents and fellows that you don't necessarily want to use a bronchodilator if you don't have to. You have to figure out what the cause is first. And if you think it's asthma, then yes, go to town and use the bronchodilator. But if you use a bronchodilator in a child with heart failure, you can actually cause them to decompensate because it increases their myocardial oxygen demands. It can make them more tachycardic. And while we'll see kids in the ICU who are on turbulent drips get very tachycardic, and things would that make you second guess yourself, they can often tolerate fairly high heart rates, assuming that they have a normal heart. But if they have an abnormal heart and they have myocardial dysfunction to begin with, a bronchodilator can increase their heart rate and cause them to decompensate.
Okay, thank you very much. Still concerning the management of bronchiolitis, you mentioned saline drops, but some also suggest hypertonic saline nebulization. What's your opinion on that?
Yeah, I mean, it depends. I don't necessarily think, the hypertonic saline is thought to break up the mucus a little bit more, and I have seen people using nebulized, saline or hypertonic saline, and there may be some role for that, but also I think of sometimes it can be an irritant of the airways, and so I typically, I mean, I can't think of anybody who I've actually used hypertonic saline myself on. Usually for airway clearance with the bronchiolitis, I typically just use regular saline drops in the nose and deep suctioning. And, oftentimes they would use like those big, nasal suctions or red robin catheters, which are softer, and they would, put the nasal catheter way deep down in the nasal pharynx down to the oral pharynx to really get the mucus out. And it's really about getting the mucus out in any way you can, whether it's hypertonic saline. I'm not sure if that adds any benefit to over regular saline when it comes to suctioning the airways.
Okay, thank you. The last question concerning respiratory support. So theoretically, non-invasive ventilation like continuous positive airway pressure can be effective by keeping the airways open. But what about practically? Is that something that is commonly used in management of patients still with bronchiolitis?
With bronchiolitis, yes. I mean, it is, simple answer, yes. I mean, we use positive pressure support to augment the airways to help with the work of breathing. But in some respects too, depending on what their gas trapping is, and we in asthmatics they have what's called intrinsic PEEP or positive expiratory pressures, which is from the gas trapping. And one of the thoughts of that in asthmatics is that you can actually intubate them and you put them on positive expiratory pressure that matches their intrinsic PEEP. So you put you dial up the PEEP to match their intrinsic PEEP, and that creates a stenting of the airways and decreases the work of breathing. And you can actually, what we used to do is intubate, when we have an intubated asthmatic, is you just put them on pressure support on the ventilator, which would mean that you wouldn't have a mandatory rate for them, and you would let them set their own inspiratory and expiratory time constants in as much as that, and using the intrinsic PEEP to stent open their airways. And so the same principle can be used in bronchiolitis or any child who has like air trapping. But with bronchiolitis, they have a mixture of atelectasis as well. And actually, I added this slide just in case this would come up. But when you're talking about lung volumes and work of breathing, you have the functional residual capacity, which is the combination of the expiratory reserve volume and the residual volumes of the lung. And when you have gas trapping, you can have your FRC, as they say, increases, and so your tidal breathing is at a level that's higher than your normal functional residual capacity. And if it's higher than FRC, you have increased work of breathing. But the same is true when you have atelectasis or lung collapse or pneumonia, infiltrate. You have your residual volume and you have a drop in your expiratory reserve volume, and you're working at a level that's on a lower end. And so on either of these sides of the normal functional residual capacity, if you're too high or if you're too low, then you're going to have increased work of breathing. And so when you have RSV, you will have maybe some gas trapping, but you also have a lot of atelectasis as well, maybe some consolidation. And so you're working at a level below your functional residual capacity, and you're having increased work of breathing. So by point of fact, adding positive pressure in as much as using high flow nasal cannula at times, or even CPAP machines, and ultimately intubation is aimed at correcting some of this lung collapse that you're seeing and atelectasis that you're seeing with RSV or bronchiolitis.
Okay, sir. Thank you very much.
Oh, my pleasure. Do you have any other questions?
Hello.
Oh, hi.
Okay, thank you for your presentation. My question is regarding, lately we've been having a lot of kids presenting here with pulmonary hypertension, which, for majority of them, we've never really been able to identify the etiology of their pulmonary hypertension. Unfortunately, majority of these, the families of these babies, most of the times are not able to afford, seeing a cardiologist for long-term follow-up. And so what we usually do with these kids is that when they get fluid overloaded and present in the clinic with respiratory distress and tight lungs, we end up just diuresing them and keeping them on oxygen, or long-term oxygen, actually, because they actually require, most of them require about like 2 or 4 weeks of continuous oxygenation before they are able to be actually wean off oxygen. And we actually been also using sildenafil in order to actually help with the pulmonary hypertension. But then that's what, for majority of them, that's where we cannot go to more than this. It's difficult. Even when you refer these children, they don't get to where they are supposed to, and so we keep readmitting, and each time they decompensate, we keep readmitting. So my question is this: how long would you actually keep this? Is there like a guideline on how long we should keep diuresing them? About the sildenafil, how long should we keep them on those medications, especially when you're kind of like, I don't know if I should call this like, you are kind of doing a such form of like palliative kind of management, which, so basically, how long can you actually go with these 2 medications? Or is there any, would you recommend something else? I don't know.
Yeah, no, that's a good question. So what are you finding is you said that the cause is unknown, but what, if you're seeing a lot of infants, is it from, heart disease? Is it from pulmonary infection?
So we've had few cases with newborns, like right after delivery. These ones, sometimes with antibiotics, some of them do well once we treat the pulmonary infection that we suspect maybe was the etiology of the cause. Now, but majority of them do present with like right-sided heart disease. Like lately, the little boy that we've been actually readmitting and over again has been having this right-sided heart failure with severe tricuspid regurgitation. And we just can't explain why. I can't just tell why is he having this. But then, I assume it's probably from, I can't really tell. Is it like the severe tricuspid regurgitation? Is it as a complication of the severe pulmonary hypertension? Or you can't really tell which of the 2 kind of started first. I don't know whether it makes sense.
Yeah.
So what I'm trying to say is that most of them will present with severe pulmonary hypertension with right-sided heart failure already, and then you don't really know what was the etiology. By the time you can't really tell what was the cause of that actually.
Yeah. It's,
so we end up on,
Oh, I'm sorry. I didn't mean to interrupt.
No, go ahead.
Yeah. It's sometimes hard. Usually with, like pulmonary hypertension in kids, we do see it's more uncommon to see primary pulmonary hypertension in children. Usually it's caused by something. So looking into the etiology and trying to figure out what the cause is the most important thing, because if you can treat the underlying cause, then you can kind of give them a little bit more of there's more hope to kind of getting them through that. Most kids don't have primary pulmonary hypertension. It's relatively rare. So, is it from, long-standing pulmonary venous obstruction? Is that a cause that's causing it? That because sometimes pulmonary venous obstruction is hard to pick up, on echo at times. But if there's an underlying, bad lung disease, yes, that can be a cause of it. But we, rarely see just primary pulmonary hypertension. So looking for the cause is very important. Congenital heart disease, we would often see pulmonary hypertension, especially in the kids who would have pulmonary over-circulation lesions for prolonged periods of time. But usually those kids, after they're repaired, they're put on sildenafil, and their cardiac dysfunction is treated, and usually they'll kind of get better over time. But for a child that kind of need oxygen and sildenafil for a prolonged period of time, is kind of unusual. But if you don't have a cause and you're not sure what the cause is, and you have pulmonary hypertension, then the onus is on you to just continue treatment. There's really, you're doing the right thing with oxygen. Sildenafil is often the mainstay of treatment for outpatient treatment for children with pulmonary hypertension. Although they can use, I've seen some older kids, on prostaglandins or prostacyclin, I should say, prostacyclin. But those types of infusions are really relegated to, really like the subspecialists who, you have a child with primary pulmonary hypertension, and they're dealt with, that on a chronic nature. Sometimes there can be situations where pretty rare things where you have like pulmonary veno-occlusive disease, where you have microthrombi in the venous system, and that can cause pulmonary hypertension. But if you're using things like sildenafil and chronic oxygen, usually that can actually make things worse, because if there's a fixed obstruction in the pulmonary venous system and you use sildenafil, it dilates the pulmonary vessels and you get more flow to the lungs, and you actually get pulmonary edema if you use those modalities. So it's hard to know. It really depends on what the etiology of the pulmonary hypertension is, and to see if you can figure out what the cause is. If there's no defined etiology for the pulmonary hypertension, then you're just obligated to treat. And yes, you can use the oxygen and the sildenafil as long as you need to, because the underlying cause hasn't been found, and you want to kind of use those to support the infant or the child until something is found, or to at least improve their quality of life. I hope is that helpful?
And is there an entity like maybe idiopathic causes? Does that exist? Like idiopathic causes, you can't just explain why.
Yeah. Sometimes we see that. And a lot of the pulmonary hypertension kids that I've seen, usually related to more underlying heart disease issues. But yes, idiopathic pulmonary hypertension can definitely exist in children. But there are also other underlying things that can cause problems too. The child that you're speaking of, which gets admitted all the time, what's the age of the child?
2.5 years.
2.5 years old. Okay. So, yeah, it definitely can happen. And there are some infants who have things like, alveolar or capillary dysplasia, where, they have chronic hypoxemia and oxygen requirement, but that usually leads to early death because they can't oxygenate, they're hypoxemic. But yes, children can have idiopathic causes for pulmonary hypertension, as they can with anything else. Like we have kids who have heart failure, and we have no cause of why they have the heart failure. You do testing for viruses and genetic problems, metabolic problems. Nothing comes out. But yeah, they can have idiopathic causes as well. But it sounds like you guys are doing all the things that you need to do to try to maintain that child, and then maybe investigate further and see if there's any other cause for it. But I mean, it sounds like you guys have done that already.
Thank you, Dr. David.
Oh, my pleasure. My pleasure.
Thank you so much, Dr. Epstein, for your wonderful lecture on behalf of Health for the World. We really appreciate your time. Thank you so much. And thank you, everyone, for joining.
It's my pleasure. Thank you so much for the invitation. And be safe and be well, everybody.
Thank you so much. Take care. Bye-bye.